السلام عليكم. نحكي على ال second part of the antibacterial lectures. We finished so far the antibacterial agents that acts mainly through inhibition of the cell wall synthesis, and we ended up by vancomycin as the last agent. Now we're going to talk about the second part, which is the protein synthesis inhibitors. Usually in the humans, we have two subunits of the ribosome. Ribosome is the place where the messenger RNA is being translated into a protein. We have two terms, transcription and translation. Transcription is when the DNA is being transformed into messenger RNA, and the translation is where the messenger RNA is being converted to multiple amino acids and protein. The place where the translation happens is called the ribosome. In the human, it consists of two subunits, the 40S and the 60S, while in bacteria or prokaryotes, it consists of two subunits, 30S and 50S, rather than 40 and the 60S. The agents that affect the protein synthesis process are listed here. We have the chloramphenicol, tetracyclines, macrolides, clindamycin, aminoglycosides, linezolid, and streptogrammin. The first thing we're going to talk about, I believe, are the amino glycosides. This is another list of the agents that function on the protein synthesis inhibition. And they start here with the tetracyclines, then the tigecycline. Tigecycline is sometimes classified as part of tetracyclines, and sometimes is being classified as part of the glycyl cyclines. Then we have the aminoglycosides, macrolides, and ketolides, chloramphenicol, clindamycin, which is part of something called the lincomycin. So lincomycin is the larger group, and clindamycin is part of the that. And then we have the streptogrammin, quinapristine, and delphopristine. So far are the only two examples of streptogrammin. And then we have the linezolid. This schematic diagram represent the ribosome complex. The upper part is the 50S and the lower part is the 30S. And then the 5 prime, 3 prime represent the messenger RNA, and the dotted one represent the nascent or the growing peptide chain. This diagram represent the site of action of the different agents or antimicrobial agents working on the protein synthesis. The chloramphenicol bind to the 50S portion and will prevent the transfer of the growing polypeptide from one tRNA to the other tRNA. The erythromycin, which is an example of the macrolide antibiotics, binds to the 50S portion of the ribosome complex and prevent the movement of the ribosome complex along the messenger RNA, and thus inhibits the translocation process. The tetracyclines bind to the 30S complex, and they interfere with the binding of the tRNA to messenger RNA. While the streptomycin is an example of the aminoglycosides. We need to keep in mind that is the aminoglycosides, the three most common ones are gentamicin, tobramycin, and amikacin, sometimes lithiumycin, but streptomycin is only used in the cases of patients suffering from tuberculosis and not as a first-line agent, rather as a second-line agent. Anyway, the aminoglycosides, they make the three-dimensional structure of the 30S portion, and this will make a miscoding. So the inappropriate tRNA will be binding to the messenger RNA, resulting in the sequence of the protein coming out of this process incorrectly sequenced. The aminoglycosides, as I said a minute ago, the most common ones are the amikacin, the gentamicin, tobramycin, the one in the red, while streptomycin is usually used as a second line agent in the cases of tuberculosis. Neomycin is usually seen in topical preparation, the ointments and the creams, and also we see it in the ocular preparation. The also can sometimes the neomycin can be used orally, like the case of vancomycin, and it is not absorbed to a significant extent. This neomycin, so it is used for the cleansing of the GI. In the case of vancomycin, it's not absorbed orally, and it is used for the treatment of pseudomembranous colitis caused by Clostridium deficit. And the pseudomembranous colitis is a result of the use of broad spectrum antibiotics, like in the case of extended spectrum penicillins or cephalosporins. Neomycin can be used orally for the cleansing of the GI before GI surgery. So let's say tomorrow a patient is scheduled to undergo GI surgery. Unfortunately, the GI is full with the fecal matter and is also being inhabited by a lot of aerobes and anaerobes, as well as the gram positive and the gram negative bacteria. The GI has to be cleansed, has to be cleaned before the initiation of surgery. That's why they give patients a laxative. They give them plenty of fluids, and afterward they use an antibiotic like neomycin orally to further cleanse the content of the GI before surgery. So, does any one of these aminoglycoside is being used orally for systematic infections? No, none of them. All of them are used parenterally, IM or IV. But in the case of neomycin, it is not absorbed but it is used orally for the cleansing of the GI surgery, for the cleansing of the GI before GI surgery. And we said also that neomycin and some other aminoglycosides, but mainly neomycin, is used topically, either in ointment or creams, skin preparation, or in eye and ears preparation. Also, sometimes these medications are used in the management of cystic fibrosis. The problem that the aminoglycosides are highly polar, and if they are given parenterally, they will not achieve adequate concentration in the pulmonary tissue in the lungs. And that's why one of the ways to administer aminoglycosides for cystic fibrosis is by the inhalation route rather than the parenteral route. So, in summary, we can use them orally, but not for systematic infection, rather for the cleansing of the GI before GI surgery. We can use them on the skin in ointments and the cream. We can use them in eye and ears preparation. They can be used parenteral in the form of IV, as well as they could be used as inhalation in the case of lung infection, in particular cystic fibrosis. Can aminoglycosides be used in pediatrics? Yes, they can be used for pediatrics. Can they be used in pregnant women? Yes, they can, but there is a fear that they may cause deafness, which is loss of hearing, or blindness, which is loss of the vision in newborn cases. That's why it is recommended that not to be used in pregnancy unless we have to use them. And if we have to use them during pregnancy, the period of administration should be limited to 5 days and not more than that. The aminoglycosides is an example of the group of aminoglycosides is an example of concentration dependent bactericidal agents, and this means that the higher the concentration in the blood, the higher the killing, and that's why different indications of aminoglycosides require different doses. So the doses of sepsis, for example, are higher than other classes of indications, like in the case of UTI. Can aminoglycoside achieve adequate concentration in the kidney? Yes, they can, and that's why they cause nephrotoxicity. So can they be used in pediatric? Yes. Can they be used in pregnant women? Yes. But we have to be cautious. We need to find another alternative. If we can't find another alternative, we need to limit the use for 5 days maximum. These medication, they have concentration dependent killing. This means that the higher the concentration, the higher the dose, the higher the concentration, the higher the killing of these agents. And this led to the suggestion of what is called single day dosing. So rather than using them 3 times or 5 times a day, you sum up all these 4 doses in a single dose and you give it only once. And in this way, you will have a much higher serum concentration, and in this way, you will have a much more killing. Another advantage for this kind of suggestion is that it was found that the adverse drug reactions of aminoglycosides are related to the time they persist in the bloodstream. The more time they spend in the bloodstream, the higher the incidence of toxicity, mainly nephrotoxicity and ototoxicity. Ototoxicity means damage to the ear, resulting in deafness, and nephrotoxicity means damage to the kidney. Do they have any other side effects? Yes, they could have a neuromuscular blocking effect, which is a muscle relaxing effect. And if this mainly happens when we administer this medication intraperitoneal, and if it happens, this can be stopped immediately by calcium gluconate or by the use of neostigmine. So why we need to stop the neuromuscular blocking effect? Because we are afraid that the skeletal muscles in charge of the breathing process may stop because of this neuromuscular blocking effect. So if it happens, we can reverse it immediately by the calcium gluconate. What is the spectrum of activity of aminoglycosides? They cover gram positive and gram negative, but usually we use them for gram negative infections, like in the case of Pseudomonas aeruginosa. But we usually are reluctant. We don't use them for gram positive activity, and but this is because we are afraid from the rapid emergence of resistance among gram positive bacteria. But in certain cases where it is a life-threatening condition, the use of vancomycin in combination with aminoglycosides or penicillins in combination with aminoglycosides can be used for the management of enterococcal endocarditis or in the case of meningitis. But generally speaking, we are supposed not to overutilize amino glycoside, which is the opposite of what's happening nowadays, where a lot of topical preparation contain some sort of amino glycosides in them, and this may lead to emergence of resistance, and we're gonna end up with no antibiotics available to counter a serious infection. One of these important infections now developing multiple drug resistance is a symptom factor. So they are useful for the treatment of UTI, and they are useful in the treatment of the intra-abdominal infection. We use them in sepsis, we use them in cystic fibrosis, and use them in febrile neutropenic patients. And what do we mean by febrile neutropenic patients? This is a condition where patients have a high temperature, and this is febrile, and at the same time the count of the neutrophil is low, and this is the neutropenic, and this happens usually in cancer patients suffering from infections. They develop febrile and neutropenic cases, which is a serious condition. And what do we mean by cystic fibrosis? It's a genetic inherited disease where patients lose the channels in charge of the chloride transport across the membranes, and this leads to the accumulation of a mucus in the lung with the subsequent infection in the lung. Unfortunately, patients with the cystic fibrosis, they have recurrent in pneumonia, and it's really very difficult to eradicate infection from cystic fibrosis patients. I think sepsis is when we have seps means that something that is alive, and sepsis mean that we have a biological entity other than our self present in the blood. This could be bacteria, this could be fungal, this could be viruses. So if it is bacteria, we call it bacteremia, and if it is viral, we call it viremia, and if it is fungal, we call it fungemia. But the most common cases of sepsis is bacterial sepsis, and the use of aminoglycosides in sepsis, because one of the potential pathogens of sepsis could be gram-negative bacilli, where aminoglycoside have distinctive activity against them. But always keep in mind that aminoglycosides are known for their activity against gram-negative bacteria, but they have also activity against gram-positive bacteria, but we tend not to use it into that direction. They have also something called the post-antibiotic effect, and we explained this thing when we discussed the penicillin, and we said that the penicillin they have something called post-antibiotic effect, where the killing duration of killing is extended beyond the period expected by the half-life of the penicillin, and that's why a medication like amoxicillin is given only 3 times, or a medication like ampicillin is given 4 times, though the half-life is much shorter than that. And why the post-antibiotic effect? It is because some of the pathogens are weakened or fragmented, and hence that the lower concentration, lower than the minimum bactericidal concentration, may be sufficient to kill them. What are the three most commonly used? Gentamicin, tobramycin, and amikacin. But we said that nitylmycin is sometimes is used in resistant cases, and also we have neomycin that is used orally to cleanse the GI, or topically an eye infection or skin infection. And also we have the streptomycin, which is used as a second line or even a third line agent for the management of TB, Mycobacterium tuberculosis. We said before that is we don't use piperacillin alone in the management of Pseudomonas aeruginosa, though they are anti-pseudomonal. And also, we said that is third generation cephalosporin, like ceftriaxone of or like ceftazidime, more Tizidine is not used alone for the management of pseudomonal infection because we are afraid from the emergence of resistance, and we combine it with other classes of medication, like in the case of aminoglycosides. Also, the carbapenem have anti-pseudomonal activity beside the aminoglycosides and the third and the fourth generation cephalosporin and the carbapenems. Also, the fluoroquinolones are among the classes of medication that have distinctive again activity against Pseudomonas. The adverse effects we have talked about ototoxicity and nephrotoxicity, and we said that when these medications are given intraperitoneally, they sometimes we're afraid from the neuromuscular paralysis. Why we're afraid from that? Because of the chances that the skeletal muscles in charge of breathing are the one being affected, and this would stop our ability to breathe. But we said that we can reverse such kind of adverse drug reaction by giving calcium gluconate, which would reverse it promptly on the spot, or we could use newstigmine. But this is for a reminder, neostigmine is indirectly acting cholinomimetic agent. We finished the aminoglycoside, which are example of bactericidal antibacterial agents targeting the protein synthesis at the 30S level. And we talk about now another agents working at the 30S level, the tetracyclines. Unlike the aminoglycosides, they are known for their bacteriostatic effect. But unlike the aminoglycosides, they have a very, maybe the one of the widest, they and the macrolides. They, the tetracyclines and the macrolides, they have very wide, broad spectrum of activity against microorganism. They affect chlamydia, they affect the mycoplasma, they affect rickettsia, they affect Vibrio cholera, Yersinia. Vibrio cholera is the causative agent of cholera. Yersinia, which is the causative agent of plague, طاعون, and the causative agent of brucellosis, brucella, اللي هو الحمى الملطية. Also, they have activity against spirochetes. They have activity against a gram-positive, a gram-negative bacteria, cocci, bacilli, aerobes, anaerobes, atypical microorganisms. They have really very wide spectrum of activity, which enables them to be used in multiple indications. One of the things that is used and not mentioned in the slides is they can be used in the management of acne. This is important because one of the side effects of tetracyclines is photosensitivity, which means upon the exposure of the sun, skin reaction would happen upon the taking of these medication. So when people are taking these things to treat acne, they need to be wearing sunblock and to avoid the direct sun exposure. We said that they are bacteriostatic. They have wide spectrum of activity. They work on the 30S, where they do three-dimensional changes in the messenger RNA, which will make a miscoding between the tRNA and the messenger RNA. The three most common used agents are tetracycline, minocycline, doxycycline. And usually when tetracycline is faced by resistant strains, we can resort to the doxycycline and the minocycline. One of the problems with the tetracyclines, because of their chemical structure, is their tendency for chelation of other cations and the chelation of other medications. That's why when we take them with milk containing calcium, or when we take them with magnesium contained in the antacid, or when we take them with aluminum salts also present in the antacid or iron supplementation, the bioavailability of the tetracyclines will be affected for a large degree. This is also seen with if we use tetracycline with fluoroquinolones, or if we use tetracycline with digoxin, with thyroxine. In summary, we have a lot of drug interaction at the level of absorption of tetracyclines because of their chemical structures. That's why it has to be kept away. It has to be kept away from the rest of the medications while we're taking these medication. Also, one of the problems with the tetracycline is their ability to cross the placenta and causing and the milk and causing teratogenicity in the fetus, or causing fetal abnormalities in the fetus, mottling of the teeth, abnormalities with the bones. That's why it is not recommended during pregnancy, and also it's not recommended for children below the age of 8 years old. A similar cautionary statement can be also seen with the fluoroquinolones, where they cause tendonitis, inflammations of the tendons, and collagen a problem in newborn and children. That's why we try to avoid them as much as possible during pregnancy. And it has been mentioned in the slides, these current slides, that we'd like not to use them under the age of 18, although I have seen so many cases of kids below the age of 18 use fluoroquinolones. So we could say maybe kids below the age of 12 years old, we should not use the fluoroquinolones with them. This picture is an illustration of the bone and teeth abnormalities that happens with the tetracyclines, where dentition, primary dentition, happen during a calcification process, and we have also a problem with the mottling of the teeth and the temporary stunning growth. So this has to be kept in mind, and that's why we should avoid using these medication during pregnancy and in children below the age of 8 years old. This picture summarizes the wide spectrum use of tetracycline from Rocky Mountain spotted fever. This is a pathogen called rickettsia, to chlamydial infection affecting urethra called urethritis. Just for clarification, urethra is the tube that comes out of the bladder. Bladder is the mathana, and the urethra is the ihlil. It is the tube that comes out of the bladder, mathana, where the urine come out during urination. So sometimes patients may suffer from urethritis, and this is caused by a chlamydial infection. Chlamydial infection can be treated with tetracyclines, can be treated with macrolides, and also can be treated with ceftriaxone, which is a third generation cephalosporin. For Rocky Mountain fever, which is the one on the right, tetracyclines are usually the drugs of choice. They have distinctive activity against Mycoplasma pneumonia bacteria. Still, it is unusual to use tetracyclines for the treatment of pneumonia caused with mycobacterium, although they have very distinctive activity against atypical microorganisms like mycoplasma. They have activity against spirochetes, the Lyme disease caused by a Borrelia, and leptospirosis caused by Leptospira. I have a distinctive activity against gram-positive, gram-negative bacteria. They have distinctive activity against anthrax, affecting the gram-positive bacilli, affecting the lung and causing death in individuals. Also, it is a drug of choice for management of cholera caused by Vibrio cholera, and also easily affecting plague, which is Yersinia, caused by Yersinia, and also it has a distinctive activity against the Brucella, the causative agents of brucellosis. Beside the teeth and the bone abnormalities, the GI side effects, they cause photosensitivity. Here it says that is dimoclocycline is the most distinctive among all of them to cause phototoxicity, but it happens across the board. It affects, it's a side effect of all tetracyclines, and as a matter of fact, nobody is using dimoclocycline as an antibacterial agent at the site of injection, local toxicity, and this vestibular abnormalities, dizziness, nausea, vomiting, especially with minocycline, and because of their broad spectrum, it is expected to suffer from super infection like candida infection, either in the mouth or in the vagina. They call it mouth thrush, or they call it vaginal thrush. Macrolide is also a group that affects the protein synthesis, mainly at the 50S site of the ribosomal complex. At low doses, they are bacteriostatic, and at higher doses, they are bactericidal. Just like the tetracycline, they have a distinctive broad spectrum activity. Beside the ones mentioned for the tetracycline, like chlamydia, mycoplasma, spirochetes. They also have activity against Legionella and activity against Listeria, in addition to a large number of gram-positive and gram-negative bacteria. So do they have activity against the chlamydia? Yes, they have. Mycobacteria, yes, they have. Spirochetes, yes, they have, against Trypanosoma pallidum. As a matter of fact, they are a replacement therapy for penicillin in the management of syphilis if a patient cannot take if the patient cannot take penicillin G, benzathine, penicillin B, C, penicillin benzathine, penicillin G as a treatment because of hypersensitivity issue. They can also be used in the management of diphtheria cases, and also in replacement of penicillin G treatment in the case of hypersensitivity. So in summary, they have really a wide spectrum of activity covering gram-positive, gram-negative, cocci, bacilli, spirochetes, typical, atypical, Legionella, chlamydia, mycoplasma, Corynebacterium diphtheria, syphilis. They have very wide spectrum of activity. In low doses, they are bacteriostatic. In high doses, they are bactericidal agents. We have three agents of them: erythromycin, clarithromycin, azithromycin, and also there is erythromycin. The one with 100% bioavailability is azithromycin, and also it has the longest duration of action, where it has a half-life of 72 hours, concentrated in the macrophages, and that's why in the management of pneumonia, they use only 3 to 5 tablets of azithromycin, and this will last for 10 to 14 days effect. In the management of pneumonia, typical community acquired pneumonia, typically we combine the penicillin or cephalosporin with macrolide. The addition of macrolide to penicillins or cephalosporins is advantageous because of their activity against the atypical microorganism like Legionella, like Mycoplasma bacterium. The longest duration of action is with azithromycin, followed by clarithromycin, and the shortest is erythromycin, where we have to use it multiple times in one day. Clarithromycin is sufficient to use it once or twice daily, while azithromycin is used once three daily for 3 consecutive days, and this or in some regimens 5 consecutive days, and this would cover either 10 or 14 days of treatment. The one with the highest bioavailability, 100% bioavailability, is azithromycin, followed by clarithromycin, which is around 80%, while in the case of erythromycin, it has a really, really very low bioavailability. That's why current preparation with erythromycin are either they are in enteric coated formulation or they are in ester forms. The ester, we have the palmitate to cover for the bad taste, bitter, bad taste, esterate, oleate, and estelate. Estelate is the one that is known to cause the highest incidence of a side effect called cholestic jaundice. The word jaundice means that our body turns into yellow. So if you look in the white ball of the eye, it becomes yellow. If you look at the nail bed, it is yellowish. If you there's paleness in the skin, this is called jaundice, and it is mostly because of an elevation in something called bilirubin. And the cholestatic means that is the movement of the bile in the biliary tract has been halted, has been stopped. This is the word cholestatic. So chole mean biliary product, and the static, that is the movement, has been stopped. If we go back to the process by which bilirubin is produced, one has to mention RBCs, red blood cells. They contain inside of them something called hemoglobin. Every 120 days, 120 يوم, RBC will go to the reticuloendothelial system, like the spleen, where it will be destroyed. Once an RBC is destroyed, what's inside of it, like hemoglobin, will go outside and it will undergo catabolism. It will be broken up into globin, which is the protein, and heme. The heme has an iron element in it and a porphyrin ring. The porphyrin ring will be broken further into bilirubin. The bilirubin will be then conjugated by the liver and will be sent to the biliary tract. And from the biliary tract, it will open up in the duodenum. And from the duodenum, it's going to go to the small intestine, and then it will part of it will go into the feces. So if we have the biliary tract clogged or blocked, so the bilirubin will not continue going forward, rather it's going to go backward, and the concentration of the bilirubin will increase, and this is going to cause jaundice. So one of the side effects of the macrolides in general and erythromycin estolate in particular is something called cholestatic jaundice. Another distinctive side effects of the macrolides is something called the QT prolongation. The QT is the distance between, if you recall an ECG, which is the electric diagram or graphing of the electricity, surface electricity that goes through the heart. It's called ECG. It stands for electrocardiogram, E electro, C cardio, and G is a gram. So it's a depiction of the surface electricity of the heart. And if you examine an ECG, you will have a P wave, a QRS wave, and you will have a T wave. The P wave is a representation of the atrial depolarization, which means that the atria الأذين will undergo depolarization, and the QRS is a representation of the ventricular depolarization in the ventricle, while the T wave is the depiction of the ventricular repolarization. So atria and ventricle undergo depolarization and undergo repolarization. If the distance between the QR is complex and the T wave extends, prolonged, this is gonna cause a kind of arrhythmia. It's a ventricular type of arrhythmia called torsade di ponte type of arrhythmia, and this is a serious kind of arrhythmia. So the and this is most obvious with the erythromycin. So going back, we have erythromycin stellate, erythromycin stearate, urate, palmitate. We have clarithromycin and we have azithromycin, and rarely you find the telithromycin. The one with the highest bioavailability is azithromycin 100%, followed by clarithromycin 80%, followed by erythromycin, which is so little. That's why it's either why it's so little, because it is destroyed by acidity in the stomach. So either we will have erythromycin base in enteric coated formulation, or in an ester format like palmitate, oleuate, esterate, estolate. And the sterate is the one that has the highest incidence of a side effect called cholestatic jaundice. We said also one of the distinctive side effects of macrolides in general and the erythromycin in particular is the QT prolongation. And because of their very wide spectrum of activity, it is expected that they would have super infections and the which requires being careful when these medications are used. As we said, that high concentration they are cidal, and at low concentration they are static. The topical formulation of erythromycin can be used for the management of acne. Also, they are very well known to be used in pneumonia, Legionella, Mycoplasma infection, chlamydial urethritis, the one we talked about when we discussed the tetracycline, in addition to spirochetes, syphilis, Treponema pallidum, and the diphtheria, Corynebacterium gram-positive bacilli. They have a very wide range of activity and a very wide range of uses because of their spectrum of activity. And this the summarizes their activities. They can be used in chlamydia. So chlamydia can be treated with tetracyclines. Chlamydia can be treated by macrolides. Chlamydia can be treated by ceftriaxone, which is a third generation cephalosporin. They also can be treated, they can be used in the management of mycoplasma pneumonia related side effects, which is the atypical part of pneumonia along the Legionella. So Legionella and mycoplasma, the two of them are atypical causative agents of pneumonia. In replacement of penicillin G, erythromycin can be used for management of syphilis. Why in replacement of penicillin G? If somebody is allergic to penicillin G, so one of the choices is the use of macrolide erythromycin, also in replacement of penicillin in the case of allergy. Also, erythromycin can be used for Corynebacterium diphtheria, al-Khanuq. So a wide range of microorganism, wide range of indications for the macrolides. They cause epigastric pain. They cause cholestatic jaundice, especially with the stellate ester of erythromycin. They cause QT prolongation with erythromycin as well as with the erythromycin. Now we finished the aminoglycosides, the tetracyclines, and the macrolide antibacterial. Now we come to lincosamide. Lincosamide, we have only a single agent, which is the clindamycin. Clindamycin has a distinctive activity against anaerobic microorganism, inclusive of Bacteroid fragilis, which is unusual by the remaining previous antibiotics we talked about previously. That's why clindamycin is a drug of choice in the management of a stabbing wound. When somebody is holding a knife and stabbing somebody is in his abdomen, the knife is usually is contaminated, causing a serious infection in the abdomen, and most probably it has Bacteroides fragilis in it. Clindamycin is a drug of choice for the management of anaerobic infection, especially those caused by Bacteroides fragilis. Also, clindamycin can cover the gram-positive cocci, the broad spectrum of clindamycin, causing them to cause a super infection because of their extended spectrum. Also, we said that the clindamycin would be a good choice in replacement of amoxicillin and ampicillin as a prophylaxis against the enterococcal endocarditis of patients undergoing dental extraction while they are having a valve replacement procedure. In case that the patient cannot take penicillins or cephalosporins because of an allergic condition. The clindamycin can cause pseudomembranous colitis because of the broad spectrum of activity causing overgrowth of a Clostridium difficile. How we can overcome Clostridium difficile either by the use of vancomycin orally or by the use of metronidazole. Metronidazole can be used either orally or can be used parenterally, but vancomycin for the treatment of Clostridium difficile pseudomembranous colitis, the only way to give it is through oral administration. Also, the kit can cause hepatic dysfunction. Chloramphenicol is another medication that works on the 50S part of the ribosomal complex with the broadest spectrum ever, covering aerobics, anaerobics, gram-positive and gram-negative organisms. Still, in Jordan, we don't have a chloramphenicol oral, we don't have a chloramphenicol IV. The only remaining preparation with the chloramphenicol are the ones that intended for ocular administration, eye administration, and the ones that are intended for ears, otic or ears administration. Most probably because of fear of production of resistance and because of the potential adversity. Chloramphenicals require that is the liver is very well and highly functioning, and that it can cause a conjugation of chloramphenicol to get rid of its toxicity. We have incidents of cases where chloramphenicol was given to children with غير ناضج, immature liver, and this led to the accumulation of chloramphenicol, which leads to gray baby syndrome. This was a serious condition. It has activity against rickettsia as well. It can have bactericidal and bacteriostatic activity depending on the organism. The only preparations or chloramphenicol currently available for ocular eyes and for ears preparation only. We could use it if it is available, and it's not available. If it is available, but it's not available as an alternative for penicillins and cephalosporins in the management of meningococcal meningitis and other cases of penicillin resistant strains of pneumococci in the case of hypersensitivity to the penicillin, but it's not available, and also serious rickettsial infection. So we have so far we have the tetracyclines and the chloramphenicol if it is available. It's not available for the management of rickettsia. Adverse effect GI disturbances, also because of its expected side effects, because of its extended spectrum of activity, is going to cause overgrowth of the candida albicans in the mouth or in the vagina, oral thrush or vaginal thrush. Also, it can cause a gray baby syndrome, vomiting, flaccidity, hyperthermia in neonates and little children, ability to get rid of the drug in a safe way. So this leads to the accumulation of chloramphenicol and leads to gray baby syndrome. Also, it can cause in certain individuals who has a glucose 6-phosphate dehydrogenase deficiency, aplastic anemia, and this happens in a dose-related reversible suppression of the RBC production, leading to aplastic anemia. So the aplastic anemia may one of the side effects of chronophenical side by side with the gray baby syndrome and the GI side effect and the overgrowth of candida in the mouth or in the vagina. The last group about the protein synthesis discussed in these slides are the streptogramins. There's still one more group called the linezolid, but unfortunately it is not discussed in the slides. The streptogramins and the linezolid are important because they are the last thing we resort to, the last defense we have against MRSA, the methicillin resistant Staph aureus, especially the V RSA, the vancomycin resistance Staph aureus, as well as the vancomycin resistance strains of the Enterococcus faecium. So they are the last resort beside the linezolid. So the linezolid streptogramins are important because they are the last thing we resort to, the last thing that we use in order to combat, to defeat, to conquer, to eradicate MRSA, methicillin-resistant Staph aureus, vancomycin resistance Staph aureus, vancomycin resistance enterococcal faecium. Just go back a little bit. We said that we have agents that can handle the MRSA situation, like the vancomycin and like the fifth generation cephalosporin. Now also we have two more, streptogramins and the linezolid. The linezolid, only we have two examples of them, quinapristine and dalfaprostine, that they have always to come in a ratio of 3 to 7 weight to weight ratio. The combination of the two will cause synergistic activity. Main site of action is on the 50S part of the ribosomal complex. Against staph, they have bactericidal activity, and against the enterococcus, they have bacteriostatic activity. As we said, the last resort we have against vancomycin resistant strains of staphylococcal and the vancomycin resistant strains of enterococcal faecium and the MRSA methicillin resistant Staph aureus. The side effects associated with the streptogramins is the hyperbilirubinemia, which is an increase in the bilirubin level in the blood, up to 25% of the patients, and arthralgia and myalgia. Arthralgia means pain in the joints, and myalgia means pain in the muscles. So, in high doses, a patient will suffer from joint pain called arthralgia and muscle pain called myalgia, as well as pain at the injection site. I think this is the last slide covering the antibacterial agents working on the protein synthesis. We covered the aminoglycosides, we covered the tetracyclines, we covered the macrolides, we covered the lincosamides, one example, which is the clindamycin. We covered the chloramphenicol, and lastly, the streptogramin. And unfortunately, we are not going to cover the linezolid. The linezolid, the streptogramin should be, as well as the fifth generation cephalosporin, should be the last resort of antibacterial that we need to use. If the use of these medications become widespread, we are facing a serious problem of not finding any antibiotics in the futures to treat serious kinds of infections. I'm going to stop here. This is the second part of the antibacterial.